Hi listeners, Julia Cheek here, founder and CEO of Everlywell, a pioneering company in biomarker intelligence that delivers essential health insights to over 60 million people and hundreds of enterprise partners over the last decade. Ever feel like you're doing everything right, but still don't feel your best? That's why we launched Everlywell 360, our most advanced lab test yet. It measures 83 key biomarkers in just one lab visit to give you a fuller picture of your health, from hormones to inflammation and beyond. If you're looking for real answers and personalized insights about your health, Everlywell 360 is the perfect place to start. Learn more at everlywell.com.
Welcome to the Heart of Healthcare podcast. I'm Hallie Tecco.
I'm Michael Esquivel.
And I'm Steve Krause. And every Monday, we bring you the latest in healthcare innovation as we sit down with entrepreneurs and industry experts.
So buckle up and join us as we figure out how to improve healthcare for all.
Hello, listeners, and welcome back to the Heart of Healthcare podcast. I'm your host, Steve Krause, and today I'm really excited to have Dr. Jaewon Ryu on the pod. Jaewon is a very accomplished healthcare executive who's made a career focused on value-based care in our country, which is a topic that we are super excited to talk about, and one of the leaders of integrated health delivery. Jaewon has a lot of impressive accolades on his resume. I won't go through them all. We'll talk a lot about them today, but he was for a long time the president and CEO of Geisinger, which is a leading integrated health system. And he served in that role until April 2024 when Geisinger and Kaiser Permanente came together to form Risant Health, which is a nonprofit organization created to expand and accelerate the adoption of value-based care across diverse health systems in the United States. So the last thing I'll say about him is also just one of the extremely good guys in our industry. And really, I say that having known him for a long time, and I think everyone would say that who knows Jaewon. So Jaewon, welcome to the Heart of Healthcare.
Thanks for having me, Steve. It's always good seeing you, and thank you for the kind words, overly kind words.
Oh, well, they're well-deserved, my friend. So let's see, you've got a lot of degrees, obviously undergrad and then MD, JD. Want to talk a little bit about that. And then worked in DC as a fellow at the White House, and then ultimately got into the practice of medicine and ultimately rose in leadership. And I'm just curious, did you from a young age know you wanted to be in healthcare? Did you know you wanted to be in value-based care? How did you get to where you are today?
So I always grew up in a healthcare household. My father was a physician. Yeah. Okay. And I remember he was an old school throwback physician, even then.
What kind of physician was he?
He's a neurologist, and he had the black bag that he would take. He was still making house calls throughout the 80s and 90s and so forth. And his practice was really a lot of chronically afflicted people. I think these are people who have things like stroke, Parkinson's, Alzheimer's, dementia, and I think movement disorders. I mean, neurology is one of those eye-opening areas of the industry where, it's a lot of chronically ill folks because these diseases are sort of debilitating for daily function. And so I remember from an early age just the relationships that he had ongoing with his patients, and we'd see them sometimes out in the community, and I think it was always kind of fascinating and something I looked up to, the fact that you could have these ongoing relationships with people and play this role throughout various facets and aspects of their lives. So I grew up in that environment, and as a result, I think medicine was always something that was sort of in the background, in the picture, and always something that I had an interest in. But I think what really happened during college was I realized that I had an interest more in the policy side of things as well, sort of how things happen, in particular urban policy. It was super formative. I think just I grew up in the suburbs of Chicago, and right. I think by and large, that's a pretty sheltered existence. And being a freshman at Yale or first year at Yale, you're pretty up close and personal to a lot of need. And that's need that you don't typically see in suburban environments. And I think what it did for me was it was an eye-opener that, there's a lot of opportunity to do better as a society. There's a lot of opportunity to do better as a country, whether you're talking about education or wealth disparity, or for that matter, healthcare. And that was anybody who had any inkling or community mindedness in that environment, tons of opportunities to get involved. And that's exactly what I did. It sort of started as youth enrichment programs. I took a gap year. Now, I guess that's what you'd call it, but it was right after college. I spent a year in the AmeriCorps program in New Haven.
Yeah, great program.
Oh, it was fantastic. And it was, a teaching program. It was another one of these broadening, eye-opening experiences that there's a lot that impacts people's lives in all communities that, if you think through it better, I think policies can really help people.
So did you go, after you graduated from Yale, and you got a JD at MD, I believe, at University of Chicago, was the JD thinking, a lot of people go to law school because, some want to be lawyers, but some also want to make a difference in terms of public policy. And how did you think about that decision?
I think it was a little bit of all of the above, but I think the primary driver was this interest in policy and trying to understand that world more. And I felt like I needed some formal training along those lines. I think the JD ends up being a pretty flexible degree in so many ways because you learn about not just the regulatory process, also the business, the transactional process around healthcare, but also sort of a lens through which to view policy. Initially, like I said, the interest was probably more urban policy, but as a result of the joint degree program, I think it started honing in on health policy and specifically payment issues.
You practiced law for a year, and then you went, and I think you became a White House fellow. Is that right? I'm curious, those two experiences, how have they shaped you as a leader and, those formative years?
You used the word I was going to use. It felt very formative. I actually did the joint degree and then extended it to go work at the law firm. And it was McDermott, Will & Emery. Got to really see and learn a ton, even in a pretty short amount of time. It was just a little over a year. And then I had to come back to finish up the tail end of the joint degree program. So I came back to pick up the last part of medical school. And then from there did my residency in emergency medicine. Again, sort of a roads converging in the ER. You see everything, inpatient, outpatient, primary care, specialty care, social issues, insured, uninsured. You got everything in the ER. And that's what drew me to that as a specialty. But after I did that residency, started practicing as an ER doc. And that's when the White House Fellows program came in, where it was a perfect opportunity for me to see government up close and personal, but also it's sort of intended to be a leadership and a public service program intended for early to mid-career folks across all different industries. And being immersed in that space for a year allowed me to see, my placement was at the Department of Veterans Affairs, obviously big healthcare operation, but also a pretty significant healthcare payer. And then about halfway through the year, I started on a detail project over at CMS. So after that year was up, I continued on at CMS because those projects were continuing around quality measurement, sort of harmonizing of quality and how you measure that and how it informs different kinds of payment models.
Then my guess is you had your choice of, given your pedigree and your experience, you probably had your choice of lots of different places to work in healthcare. But I think you ended up at Kaiser, which is sort of comes full circle. We're going to talk about Kaiser. Was it because you now had sort of honed the sort of your mission statement, the Jaewon mission statement of I want to work in value-based care, or was it more happenstance?
I always loved the model. The very first insurance that I ever bought outside of my being on your parents' coverage, the very first insurance I ever bought was Kaiser when I was out in LA working at the law firm that year. And I first experienced the model as a member and then started practicing there as an ER doc, so experienced it as a practicing physician and saw the difference of what you can do when you have that integration of payer and delivery and programs that are sort of surrounding that patient so that it's beyond just the immediate episode in front of you. And so I was always a big fan of the model. And then even some of the work that we were doing at CMS, a lot of it was trying to create more accountable kind of integrated frameworks of care delivery, resembling aspects of Kaiser. And so to me, having an opportunity to work in that kind of an organization, it was a no-brainer, and I was lucky enough to have it. And it came at a time when they were really investing in the Mid-Atlantic region of the organization as well. And so it was just an exciting time to be there. And of course, I was already in the DC metropolitan area. So a bunch of things just happened to come together.
Let's use this as a jumping point to talk about what an integrated healthcare delivery experience means, because I'm not sure most of America doesn't have that experience. And so let's start with actually your first experience with the system, which was a member or a patient. How would you describe the difference? What actually is an integrative healthcare delivery system? And then talk about what it means for the member perspective.
Yeah, and this gets to something we may end up covering later with Risant Health, because it is a different model than the tried and true Kaiser Permanente. But at Kaiser, for those who don't know, the people who are there as patients typically carry the Kaiser insurance, Kaiser Permanente insurance, and the people that are members of the insurance product typically get their care within the Kaiser Permanente facilities, but from the Permanente physicians. And so there's sort of a total integration between the payment arm and the delivery arm of what you experience, generally speaking. As a result, you sort of see the difference. I think the biggest and most stark contrast for me was during my time practicing as an ER doc there. You could have two people sitting in the bed right next to each other, and they're both there for, congestive heart failure. And with one, let's say the Kaiser Permanente member, you could probably send them home because you could rely on the fact that there was all these programs they could take advantage of, a CHF nurse team that would go out and check on them in the home, maybe even take some medications to continue to control the fluid levels in their body. Versus if someone came in with other insurance that didn't have those wraparound support programs, you may end up having to admit that patient because you couldn't rely on the fact that they were going to have that support following up on them later that day or tomorrow or 2 days from now. I think that's an eye-opener for any ER physician, because you literally see two identical cases, and with one, you got to admit them in. With the other, they can go home.
I like how you describe it from a physician's perspective, even ER physician perspective, because you're seeing a lot of different, it's in a great A/B test almost, right?
Oh, yeah.
As we talk about in the innovation world. So there's lots of scaffolding around you as a physician that you feel like there's almost a safety net that when that person leaves the four walls of your emergency room, your hospital, they're going to be taken care of.
Bingo. But that gives you tremendous peace of mind as a clinician to know that your patient is going to be well cared for even after they leave your care. And that gives you trust to make decisions based on knowing those appointments are going to happen, knowing those visits are going to happen, knowing those check-ins are going to happen. Because the whole specialty of ER, you're only seeing patients in one snapshot in time. And so there's a lot of concern about, what's going to happen if no one lays eyes on this patient for a second time? And that drives a lot of unnecessary admission, believe it or not, simply because you don't know and you can't rely on that follow-up happening. And so I think that integrated care model really brings so many more resources to bear. And that center of gravity, which I frequently kind of describe it that way, I think the traditional healthcare industry in this country tends to be very downstream as far as where that center of gravity resides. It's the ER, it's the hospital, it's advanced disease progression, what have you. But if you're able to deliver or engineer a system that the center of gravity actually sits further upstream, that's a very different model, and it yields very different outcomes.
You have this perspective of working in front lines of one of the leading integrated health delivery organizations, the Kaiser, back in the mid 2000s, right? Before we had a lot of value-based care initiatives, before we had digital health technologies that came, before we had even EMR adoption. And so I think you have an interesting seat. A lot of the times I have to remind people that we're only really a decade and a half into sort of the digitization and valuation of our industries, because I think a lot of people are frustrated that there hasn't been more success. How do you foot where we are as a system writ large, now, what would it be almost 2 decades later? Like, how do you think about the progress?
I always think about that, and I'm going to butcher the saying, so I won't even try, but it's something around the concept that change is always frustratingly slow in the near term. But then when you rewind the tape and look back in the rearview mirror, like further out, like 10 years ago, what was it like? 20 years ago, what was it like? Decent amount of change. And so I think it sort of depends on your perspective. It always feels too slow. But if you compare right now in 2025 versus when I was practicing there 06, 07, roughly 20 years, it really is night and day. And that's not just Kaiser, it's sort of the industry, right? I mean, they're electronic medical records. I remember back then, electronic medical order entry was a big deal. I think if you look at it through that lens, tremendous progress. And then, yes, there are some other lenses you could look at it through and say, we're still on the frustratingly slow side of things. And for me personally, and where I've been professionally, that intersection of payment and delivery, I think that has been slower than what any of us would like, because I do think it yields a very different style and delivery of healthcare that net, writ large, better for the country, better for communities.
Why do you think we've been slower than you would have hoped?
I think it requires, some of the thinking, and maybe this still exists to some degree, but folks think it's solely about the payment, that, hey, you could put episode-based payments or bundles of payments or population-based payments. You can capitate folks, and that's the answer, and miraculously everything else should click into place. I think that's the beginning. It's not the end. It's the care delivery itself is what needs to be changed and adapted and sort of catalyzed and transformed. And shifting that center of gravity, like what I was alluding to earlier, it's not something that's a light switch flip. It's pretty significant re-engineering of things that can be addressed further upstream, getting earlier in any disease process, having the tools at your fingertips to do that. And yes, the financial incentives that help to create the right environment for that to happen. But even aside from the financial incentives, I think there are plenty of incentives that help to drive towards that, even in a traditional, let's say, fee-for-service environment. There's always incentive to decant things from hospitals that don't need to be there, simply so you could optimize your capacity for the more complex cases that do need to be there. And so I think we're still in that part of the journey where folks are investing in redefining and transforming how care is delivered. And that is a slow process. Faster in some areas than others, but writ large, slower than we would like to see.
So I'm going to sort of fast forward through your career. You actually went and was the CMO of a more traditional academic medical center, as I referenced, at University of Illinois. And then you went and worked for Humana, and you were the head of the integrated care delivery arm of Humana. And Humana is one of the leaders, or at least had been early days leaders of pushing value-based care from the insurance perspective. But then you get the call, I assume, for the dream job. I'm sure, on the resume, being the leader of Geisinger is a pretty appealing call, but you're going to move to Danville, Pennsylvania, which is a unique place. So I just would love to talk through kind of when you got that call, kind of how did you think about it, and where was Geisinger when you first started working there?
So Geisinger is one of these places that does both payment and delivery, and that is always the environment where I felt most at home.
It's like a Kaiser, but in rural Pennsylvania, basically, right?
And in a mixed model, meaning that may be half of what they do, but the other half is still partnering with other payers, and on the payer side, partnering with independent docs and local hospitals, regional health systems, what have you. And so that pluralistic multi-payer, multi-provider, and multi-payment model environment actually affords tremendous opportunity too. You can grow clinical programs and get scale in clinical programs that may not occur if you relied solely on your insured lives. And so it allows you to really meet the needs of the community in two different dimensions. And of course, when those dimensions come together, it's magical because you're really able to bring that fully integrated experience.
I was going to ask you, so I guess I'll put it on two dimensions. Let's talk about clinical outcomes and financial outcomes as it relates to Geisinger. My guess would be the Geisinger model, i.e. Geisinger is the payer, Geisinger is the provider, has the best. But then you have Geisinger as the provider and somebody else is the payer. That's one option. And then you have Geisinger as the payer and someone else as the provider. Talk about what you saw in terms of clinical outcomes and even financial outcomes in those different models. What's the experience given that it's pluralistic, as you said, in a mixed model?
Yeah, so your intuition is pretty spot on. So where we have Geisinger as the payer, Geisinger as the delivery system, those outcomes were always better. And it should be the case because it is fully integrated. Where Geisinger is the provider, and I think to some degree, this is a truism beyond just Geisinger, but with any provider where you have other payer, I think the understanding of exactly what those outcomes are sometimes is tricky. You don't even have the availability of information or the fullness of the information. You may have some quality information, but not the financial. And bringing those together, it's trickier to make those conclusions. I think with the traditional Medicare is where you do have more opportunity to see, especially if you're part of an ACO program, you could see how you're doing on cost of care and the quality measures. And, historically and currently, Geisinger and their ACO does very well. And then if you flip it around and you're the payer, you see the payer information, but sometimes you're not seeing the full clinical information because those folks may be getting their care at a bunch of different places. And so I think that is some of the complexity around these pluralistic systems, is that you have missing chunks of information and data, but you're still able to make a difference if you create the right care delivery model, is what I would say. And you could see some of the leading indicators. You might not see every last bit of information, but or have a general sense how you're performing. But the magic is in that sweet spot where you're the payer, you're the provider.
What are you most proud about from your tenure at Geisinger?
I think it's trying to bring the mentality of the payment arm and the delivery arm closer together.
What do you mean by that?
Being mindful of the fact that those on the delivery system side, being mindful of the fact that, wow, half of these folks, you have another way to impact their health. It's not just in the clinics and in the hospitals and programs that you have surrounding that. You could also put programs into the home. You could also do things from a care management standpoint. You have the right set of financial incentives to do that. And then on the payment side, same thing. It's sort of, yes, of course, you're still going to be pluralistic. You still want to partner with any and all partners that want to partner with you. But my goodness, you have the ability to actually launch some care delivery programs where you see gaps and opportunities. I think that's a great place to be, where you're really taking advantage of every lever you have so that you're building things and capabilities that can improve the health of your populations and the communities.
One of the things that when we last did a podcast together, you were just launching what I thought was a really cool initiative called the Fresh Food Pharmacy. What did you guys see in terms of outcomes, and how did you make that work? Like, that's an example of something I think you could do that you wouldn't do in a fee-for-service model or an academic medical center, because for the whole host of reasons we've just been talking about. But you were able to take the initiative to create something that was really innovative, and I'm curious what you saw and how did you do it?
Yeah, and it was actually launched while I was the chief medical officer there. It was under my predecessor, David Feinberg, who recruited me there.
Right.
And he was spot on. And I think it was driven off of really real needs in the community around food insecurity. But also, if you talk to any of our physicians or the clinical teams taking care of these patients, food is always a challenge. Social issues are always a challenge. And so creating a way that those challenges could be addressed so that it became easier to take care of patients who may have diabetes that's not as well controlled as they need to be, or diet that needs to be made easier because they live in environments or communities where access to healthy foods is very, very, very difficult. And so that's how the program was born. And then, yes, we did scale it, I think, or scaled it by opening 2 more sites.
You literally had sites. These were sites.
Oh, yeah. Yeah. So the first site was sort of on the side of one of our hospital campuses, smaller hospital campuses.
Are they like distribution centers or warehouse? Like, is this where you're storing the food, or what are the sites?
Yeah. If you walked in, you would think these are food pantries or something like that. They're refrigerated because you got fresh produce all over the place. You got lean meats. You have trying to have as many healthy alternatives as possible. They are also paired with sort of dietitian coaching and tips on how to prepare healthier meals. So there may be recipes and in some sites sort of cooking classes that go along with it. So it's more of a comprehensive suite of things. But I think the coaching is really what differentiates it, because otherwise it would be similar to just a healthier food pantry. But the coaching is what brings it all together. But the impact, as you would imagine, is one, clinical. It shouldn't surprise folks. There's better management of diabetes when you're really making a difference in how people are eating. And, you could look at weight loss, you could look at hemoglobin A1C. The other is, yes, we did see some improvement on total cost of care as well, just in terms of ER utilization, hospital admission rates. And that, I think, correlates pretty strongly with just the improved clinical outcomes. A lot of people ask about the economics. Is this kind of model sustainable if you're a health plan, let's say?
Right.
And I think the jury's still out on that because the program was supported in a mixed model through some grant funding, but also, of course, a lot of these patients we had risk on because they were our health plan members. And so we had several different arms of the economics where it made sense. But, if you subtracted out the donor community and the grants, I don't know, to be honest with you. And I think the jury would still be out on that.
Yeah, I appreciate the candor. That's really interesting. So you were CEO, you started as CMO as you referenced, and then you were CEO for 6 years as Geisinger. I'm sure you were happy, making a difference, building the organization. Then Risant Health merger, nonprofit collaboration. To be honest, Jaewon, I don't exactly know what Risant Health is. So I wanted to use this moment to educate me and educate our listeners, because it is obviously a combination of two of the leading, healthcare stalwarts in America. But what is it? Tell our listeners what Risant is.
Yeah.
And how it came together.
Absolutely. I love telling this story because it's really good stuff. Risant is a NewCo nonprofit started by Kaiser Permanente. So they really launched this. And it was really out of a recognition that a lot of the capabilities around value-based care, thinking of care of populations, care of communities, transforming how care is delivered in all the ways that we've been talking about. I think there was a recognition by Kaiser that there are decades of expertise there in how to do that, but that a lot of that expertise can be transported outside of that fully integrated model of care and coverage, and then also applied to pluralistic models like systems like Geisinger or Cone Health would be operating in. And so that was the vision that led to the creation. And subsequent to that, Geisinger became the inaugural system to be acquired into the model. And then since then, we've added Cone Health late last year. It's actually interesting if you look at the prototypes of Geisinger and Cone, they differ a little bit as well. Geisinger bears risk on populations through its ACO, but also predominantly through its health plan. Cone Health has a much smaller health plan footprint, but bears risk through mostly its ACO and its clinically integrated network, where they participate not just in the CMS ACO program, but they also have downside risk exposure with other health plans. And so anyway, nowadays there are multiple paths to manage a population in that kind of a construct. But once you have those populations that you're responsible for, having those capabilities to manage that health better, I think that's what a huge part of what Risant does. So
what could Risant do that Geisinger couldn't do? In other words, what did Geisinger benefit from joining Risant?
I think there are a few things. One is there is a benefit, even on the more traditional sides of healthcare and health systems, on system kind of scale and efficiency. So whether you're talking about areas like treasury or investments or purchasing, supply chain, those are all examples of where there's significant benefit. Now, Risant is different than your typical hospital M&A in the sense that normally what you would see is an entity gets acquired, the NewCo goes in, strips out the ERP, strips out the EMR, redoes rev cycle. And yes, there is value to be created there, but our model is specifically not touching those things because we feel like there's an awful lot of disruption that comes with that. And we also think that there's a huge value to maintaining the localness of the brand, the identity, those operating teams, the management teams, the board. They should continue to have an awful lot of insight and input for sure in their operations, but even over service planning, strategy, and so forth. And so it preserves that, taps into some of those more traditional areas of synergy, like the ones I mentioned. But, within that, you may get 100, 150 basis points. It's not insignificant, but it's also not significant enough to do a deal like this. I think what makes it significant enough to do a deal like this is really in what we've been calling the value-based platform. And that is the suite of capabilities, services, processes, expertise that bring together how to manage care in that different way, how to transform and shift the center of gravity in the ways that we've been describing, whether that's on the inpatient side or on the outpatient side, systematizing best practice, sort of process re-engineering so that can happen more reliably, but also more effectively.
Is there an example in Geisinger? Because I assume Geisinger knew a lot about this. What's an example where 1 + 1 = 3 here from the value-based care side?
I think it's probably worth touching on your point earlier. Geisinger was doing a lot of this work already, but we also knew we can go faster. We also knew that there were investments that could help us on this journey, especially with where tech was going and the degree to which tech can really enable and power this journey. And for all those reasons, I think that's how the transaction itself, and that's why the model of Risant really made sense. Some examples, we launched in the fall the first wave of solutions. As part of that, one of them was evidence-based care guides focused in the primary care setting. Wave 2, coming probably by the end of this year, knock on wood, is going to focus on some targeted specialty areas. But the ones that we went live with in that first wave were the primary care ones. Of course, we're seeing greater consistency of approach around those clinical conditions. But the thing that I'm most excited about is we've also seen a 6% relative reduction in the rate of specialty referral. It sounds like a small number. It ends up being a fair amount. Lot of money. It's a lot, because not just on the total cost of care side, of course, that's savings. But even if you're in a traditional fee-for-service reimbursement model, that's actually a great thing, because that's hundreds, if not thousands, of appointments that have been decanted from those specialty clinics. And given access challenges that abound throughout the industry, there are tons of people still waiting to be seen in each of those specialties. Now, typically what you find is the person that you've now been able to accommodate and see more timely is almost always more complex than the person that you were able to decant and address their needs in the primary care setting. And so even in a traditional fee-for-service model, that's actually financially a winner, because you've just upped your level of severity of that clinical visit and you've optimized your capacity. But the more important thing is it's better care, because you're addressing the needs of patients faster, sooner, without an extra step. And patients like that, as they should, and it shouldn't surprise anybody, those outcomes are going to be better.
That's a great example. I appreciate you going deep. I did want to ask you, pulling up a little bit, as we talk about the arc of 20 years and what you and I have seen in terms of improvement in the industry, I would actually say, I wonder how far we're going to get on value-based care. But I actually think we've made a lot of progress. Like, there's actually been a lot of successful, innovative companies in the primary care space. So I'd say value-based care, primary care, well, we've got a long way to go. Lots of stars in terms of success to be proud of. Specialty care, is value-based care going to work there? And my question to you is, by definition, aren't specialists going to get paid less in a value-based care model over time?
I don't think so. And here's why. I actually think value-based care will be successful in all environments. And the reason for that is we'll be forced to be. There's capacity constraints everywhere throughout the healthcare industry, whether you're talking hospitals that are overcrowded, access continues to be really challenged for primary and specialty. The average time that someone waits to see a specialist in this country is more than a month. And some specialties, it's even worse than that. Given all of these challenges, you've got to optimize the capacity that's there. And if you're trying to optimize the capacity that's there, you're really looking at ways to take care of people in different environments through different ways. That is core to value-based care. And so for those reasons, I think there's also a labor dynamic that we're looking at as a country, where you've heard about impending physician shortages, impending shortages in primary care and specialty care. I think we're going to have a lot of forces, macro forces, that really put more wind behind the sails of value-based care, because we're going to need to be there. Here's another very macro factoid that I frequently share because it's sort of daunting. In the late 60s, when the Medicare program was started, there was 4.5 workers defined as 18 to 64, traditional working age population, for every one Medicare beneficiary. In 2022, that ratio had dropped to 2.9. And by 2030, it's projected to drop further to 2.4.
The silver tsunami.
Yeah. So where are all the workers going to come from if we're still sticking with the same care delivery
You're talking
model.
about where the specialist is going to come from almost.
Absolutely.
Yeah.
Or the people that support those specialists in the clinics and so forth. I'll use that same example of congestive heart failure. As an ER physician, if I had to admit that person, if you combine everybody who touches that patient in the ER, whether they're a physician, a nurse, respiratory therapy, whoever, and then follow them upstairs, maybe even in the ICU, maybe a monitored bed, all the way to discharge, there's probably easily 20, 25, maybe even 30 people that have to touch the care of that patient. Versus if I could figure out how to get somebody into the home, hang some IV diuretics, get ahead of that issue. Maybe it's a nurse, a care manager, maybe it's a physician, maybe an advanced practitioner, who knows? I need 2 people in a car. That's a very different labor equation and a more sustainable one given some of these macro forces that are going to hit over the next decade or 2.
Hey, Jaewon, this has been, as always, a masterclass in value-based care and everything integrated healthcare delivery. It's really interesting. I think Risant and this opportunity for you kind of encapsulates your career. And frankly, your career aligns in a time fashion with our move as a country to value-based care, right? Because if we look back, there were only a few systems who could do this, right? It took a lot of investment in things like technology and care redesign and frankly, funding payment models, right? Because you have to take some risk up front to get paid later. And so there were a few organizations who could do that. And then the government came in where you worked for a period of time and actually put some fuel on the fire to let more organizations do it. And now we have enough organizations where you can have a company or a nonprofit like Risant who's trying to do this at scale. It's kind of interesting. It's a real symmetry to what you've done in your career. So I'm sure it's super rewarding. I thank you for what you've done in being a leader in this space. Honestly, it's hard work and we need people like you to drive it forward. So thank you for coming on to the Heart of Healthcare and sharing the story. And I wish you all the best of success in your new role at Risant.
Thanks so much, Steve. It's always fun.
Thanks for listening to The Heart of Healthcare. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and review. And don't forget to subscribe. The Heart of Healthcare is produced by Hallie Tecco and hosted by Michael Esquivel, Steve Krause, and Hallie Tecco. The show is engineered, edited, and mixed by Kyle Moore. Visit our website, heartofhealthcarepodcast.com, for show notes and details.